Hi everyone, my name is Med2Med. This video is going to be all about encephalitis. I've seen a few patients presenting with this, so I thought it would be an interesting topic to explore. These notes are based on the following resources. I've been using Scott's Notes recently, a PDF with concise notes of everything you need to know for medicine on the wards. As always, I've been using the Oxford Handbook of Clinical Medicine and utilising the NICE guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. So all encephalitis means is just inflammation of the brain. The etymology of the word derives from Greek, encephalos meaning brain, and itis meaning inflammation. When you take a patient's history, they will often report some infection-like symptoms before the more serious signs began to onset. They might describe themselves as having a high temperature, a rash, raised lymph nodes, potentially cold sores or conjunctivitis, and signs of meningeal involvement. So these infectious signs are really key in diagnosing encephalitis in particular and not encephalopathy. So the patient may describe these previous infectious symptoms but present with new, different symptoms, and these suggest brain involvement. So that's things like odd behaviour, we call this encephalopathic behaviour or confusion, a poor GCS, focal neurological signs, seizures, fever, headache, and when you take a history, they might describe a recent travel or an animal bite, and they might mention that they've had a recent infection. Because this is an infection, the causes of encephalitis are either viral or non-viral, which we'll look into now. So most encephalitis cases are usually viral, but there are so many different types of viruses which can cause it. It's worth just casting your eye over them and memorising a few, perhaps recognising things that you might come across regularly, such as herpes simplex virus or HIV. Some are more appropriate depending on where the patient has travelled to. And then of course we have the bacterial causes. Again, there's a lot to look at here, but just keeping these things in mind can be really useful. And as we've already mentioned for the viral causes, we need to think back to our patient's history, for instance where they've travelled to, whether they've been in large bodies of water, whether there's mosquitoes present in the area, and then you'd want to consider different bacteria. You need to do some investigations to find out what's caused this encephalitis. So first, you might do some blood cultures and serum for a viral PCR. You should do a throat swab and MSU as well. Toxoplasma IgM titer is worth doing, and a malaria film if indicated. Then, you look at doing some scans like a CT, particularly before you do an LP. If there is focal bilateral temporal or lobe involvement, you're thinking that it's herpes simplex virus encephalitis. If there's meningeal enhancement, you're going to consider meningoencephalitis. So things on CT can really indicate what is causing this encephalitis. Then you can do a lumbar puncture with a viral PCR of the CSF. And there's various things you can look for in the CSF as well. Lastly, you need to do urgent EEG. It doesn't necessarily show the cause of the encephalitis, but it will confirm the diagnosis. Unfortunately, if viral encephalitis is untreated, there's a mortality rate of 70%, so we need to be really quick with our identification and management. Okay, we've identified the symptoms of encephalitis as well as the patient recalling this infectious prodrome. We've noticed that on investigation it still indicates encephalitis, so what do you want to do? The first thing you need to do is give a cyclovir stat, so that's within 30 minutes of the patient arriving at hospital. And you give them 10 mg per kilogram per 8 hours via IV over 1 hour. You want to do this for 14 days or 21 days if they're immunosuppressed. You might want to consider specific therapies depending on the pathogen as well. You give some supportive therapy and symptomatic treatment too. So for instance, if they're seizing, you give phenytoin. When we go back to the history, if they really can't recall any infectious symptoms at the beginning, you do need to consider encephalopathy as opposed to encephalitis. So this is brain disease. The things that can cause this are hypoglycemia, hepatic encephalopathy, diabetic ketoacidosis, drugs, hypoxic brain injury, uremia, lupus, and Wernicke's. Okay, that was a whistle-stop tour through encephalitis, so let's recap. Firstly, encephalitis is an inflammation of the brain caused by a bacteria or a virus. It has a high mortality rate if it's left untreated. Patients tend to have this infectious prodrome symptoms beforehand, so things like a rash, raised lymph nodes, that sort of thing. Then they get the newer symptoms like fever, reduced consciousness, headache, focal neurosigns, and confusion. So there's quite a few specific tests you'll need to do, but if you're going to do an LP, you should do a CT beforehand. In order to treat encephalitis, the general treatment is stacked IV acyclovir, which is continued for around 14 days. Lastly, if there is nothing that suggests this is infectious, you should consider encephalopathy. And that's it. Thank you for listening.